Every morning, without thinking about it, you roll out of bed and walk to the bathroom. You reach for your toothbrush. You brush your teeth. You have done this your entire life. Your parents told you to do it. Your dentist told you to do it. Every piece of health advice you have ever received confirmed it. Brush first thing in the morning. It is one of the most automatic health behaviors that exists. And the reason most people do it first, before coffee, before breakfast, before anything, is that the mouth feels stale overnight, and brushing fixes that. The logic feels airtight, the habit feels responsible, and for a significant proportion of seniors, it is actively damaging their teeth every single morning. What I am about to show you does not mean stop brushing your teeth. It means understanding what your mouth is doing overnight, what brushing in that specific biological environment actually does to your enamel, and why the timing and sequence of your morning oral care routine can be the difference between protecting your teeth for decades and accelerating the erosion that is already happening faster in seniors than in any other age group. The science on this has been available in the dental literature for years. Most patients never hear it because the appointment is too short and the habit is too entrenched. I am Dr. Edward. Before anything else, what you are about to hear is educational information based on published scientific research. It is not a substitute for personalized dental or medical care. If you have specific dental conditions including advanced gum disease, exposed root surfaces, active tooth decay, or are on medications affecting saliva production, please discuss any changes to your oral hygiene routine with your dentist before implementing them. And if you are not subscribed to this channel yet, please do that right now. I cover the research that changes everyday health decisions. The kind your appointments do not have time for. It is free, and it takes 2 seconds. Subscribe and stay with me because what happens in your mouth while you sleep is considerably more interesting and more important than most people realize. Let me start by describing what your mouth is actually doing during the 8 hours you are asleep, because this is the foundation of everything else I am going to tell you. During waking hours, your salivary glands produce approximately 1 to 1.5 liters of saliva per day. Saliva is not simply moisture. It is a biologically active fluid that performs a remarkable set of protective functions continuously. It contains proteins called mucins that coat the tooth surface and protect enamel. It contains lysozyme, lactoferrin, and immunoglobulin A, antibacterial compounds that keep the oral bacterial population in check. It contains bicarbonate, which acts as a pH buffer, neutralizing the acids produced by bacteria as they metabolize carbohydrates, and it contains calcium and phosphate ions that actively remineralize the early-stage microscopic erosions that occur on enamel throughout the day. Saliva is, in effect, the primary defense system of the oral cavity, running continuously and automatically. While you sleep, salivary flow drops by approximately 75 to 85%. This is not incidental. It is physiological. The parasympathetic nervous system activity that drives salivary production is suppressed during sleep. The mouth becomes significantly drier. The antibacterial proteins fall to a fraction of their waking concentration. The pH buffer becomes minimal, and the roughly 700 species of bacteria that live in the human oral cavity, the oral microbiome, find themselves in an environment with dramatically reduced competition and dramatically reduced chemical defense. They proliferate. They metabolize whatever residual sugars and carbohydrates remain on tooth surfaces and between teeth, and as a byproduct of that metabolism, they produce organic acids, primarily lactic acid and acetic acid, that are released directly onto tooth surfaces throughout the night. By the time you wake up, the pH of your mouth, which should ideally sit around neutral at 7.0, has dropped significantly. Research using continuous intraoral pH monitoring has found that morning mouth pH commonly sits between 6.0 and 6.5 in adults and in individuals with larger overnight bacterial populations. Those with more plaque, with less effective saliva buffering, or with diets high in fermentable carbohydrates, it can fall below 5.5. This matters because 5.5 is the critical demineralization threshold for tooth enamel. Below that pH, hydroxyapatite, the mineral crystal that makes up 96% of enamel by weight, begins to dissolve. Enamel is being chemically attacked. This is the environment your mouth is in when you reach for your toothbrush first thing in the morning. And here is where the problem begins. Toothbrush bristles, even soft ones, create mechanical abrasive action on the tooth surface. Under normal conditions, when saliva is flowing, when the oral pH is neutral or alkaline, when the enamel is in a fully mineralized state, this abrasive action is entirely manageable and appropriate. The bristles remove plaque, clean the tooth surface, and the enamel handles the minor mechanical stress without damage. But when enamel has been sitting in an acidic environment for 6 to 8 hours, its surface is in a partially demineralized state. The mineral crystals at the outermost enamel layer have been chemically weakened. That softened surface is now significantly more vulnerable to mechanical abrasion than healthy enamel is. Brushing in that acidic, partially demineralized state does not clean teeth in the same way it does at other times. It physically removes weakened enamel crystals that, given the right conditions, specifically sufficient time, adequate saliva, and appropriate remineralization, would have recovered. Saliva remineralizes enamel continuously when the pH rises above the critical threshold. The calcium and phosphate in saliva literally rebuild the surface layer. But when you brush before that remineralization can occur, you are abrading away a softened surface that was in the process of recovering. A study published in the European Journal of Oral Sciences measured enamel wear in subjects using soft bristle toothbrushes under controlled pH conditions. When brushing occurred in an acidic pH environment, mimicking the morning oral environment, enamel wear was significantly greater than when brushing occurred at neutral pH, using identical brushing force and duration. The mechanical abrasive load had not changed. The enamel's ability to resist that load had. The acid had done the damage. The toothbrush had removed the evidence. Now I need to address something directly, because I know this is going to generate a specific objection. If the bacteria in my mouth have been producing acid all night, should I not brush to remove those bacteria as quickly as possible? Is the answer not to brush sooner rather than later? This is the intuitive response, and it is understandable, but it reflects a misunderstanding of the relevant biology. Removing the bacteria does not retroactively neutralize the acid they have already produced. The enamel surface that has been sitting in that acidic environment for hours is softened, regardless of whether the bacteria are still present when you brush. Brushing removes the bacteria, yes, but it also abrades the enamel surface that the bacteria's acid has already weakened. The sequence matters. The pH of the environment at the moment of brushing determines how much enamel the brushing removes. There is also a second mechanism that most people have never considered, and this one is specific to what the majority of seniors do in the first 15 to 30 minutes after waking. They drink orange juice. They take morning supplements with vitamin C. They have their first cup of coffee. All three of these are acidic. Orange juice sits at a pH of approximately 3.5 to 4.0. Regular coffee sits at 4.5 to 5.0. A glass of water with a vitamin C supplement sits at 3.0 to 4.0 depending on the dose. Each of these drops the oral pH below the enamel demineralization threshold even further and extends the window of enamel vulnerability. Brushing at any point during or immediately after consuming these substances accelerates enamel loss through exactly the mechanism I described. Subscribe to this channel right now if this is making you rethink your morning routine. This is the kind of research I publish every week, not to alarm you, but to give you accurate information that actually changes what you do. Tap that subscribe button and it will always find you. Here is where the science gets more nuanced and where I want to give you the specific guidance that is supported by the dental research literature rather than a simple rule. The recommendation that has emerged from the research is not to avoid brushing in the morning. It is to restructure when in the morning sequence brushing occurs, and to understand the relationship between acid exposure, enamel recovery time, and brushing efficacy. The most protective morning oral hygiene protocol, based on the available research, works as follows. When you first wake up, before you eat or drink anything acidic, rinse your mouth thoroughly with water for 30 seconds. This does several things simultaneously. It mechanically disrupts the bacterial film that has accumulated overnight. It begins to dilute the acids produced overnight and raises the pH toward neutral. It rehydrates the oral tissues, and it does not involve brushing against a softened enamel surface because the acids have not yet been further challenged by food or drink. At this point, you have two evidence-supported options for where brushing fits into the morning. The first option, and this is the one supported by the most dental research and the one that many periodontists recommend, is to brush before eating breakfast. Not immediately upon waking with no preparation, but after that initial water rinse and after any morning medications have been taken. Brushing before breakfast deposits fluoride onto the enamel surface before it is exposed to the acidic and sugary components of a typical morning meal. That fluoride coating, if you are using a fluoride toothpaste and you're not rinsing immediately after brushing, forms a temporary protective layer that reduces the demineralization that occurs during eating. This approach requires waiting at least 20 to 30 minutes after your initial waking rinse before brushing to allow some salivary flow to restore and for the overnight pH to begin normalizing. The second option, brushing after breakfast, is only protective for your enamel if you observe a minimum waiting period of 30 to 60 minutes after your last acidic food or drink before picking up the toothbrush. This waiting period allows saliva to buffer the post-meal acid load, to remineralize the enamel surface that the meal has transiently softened, and to restore the oral pH above the safe brushing threshold. Brushing at 15 minutes after breakfast, which is what most people do, provides the worst of both options. The enamel is still in a demineralized state from the morning acid environment, has been further challenged by the acidic components of breakfast, and is now being mechanically abraded at peak vulnerability. For seniors specifically, the stakes of this timing are higher than for younger adults for three reasons that I want to explain clearly. First, enamel thins with age. You are born with a fixed amount of enamel. It does not regenerate in a meaningful sense. The cells that produce enamel, called ameloblasts, are no longer present in the adult tooth. The only recovery mechanism available is the surface remineralization I described, saliva rebuilding the outermost mineral layer when pH is favorable. But the total enamel thickness, once worn, is gone. Research using quantitative light fluorescence, a technique that measures enamel thickness optically, has found that adults over 60 typically have 20 to 40% less enamel than young adults, representing a lifetime of accumulated wear that has eroded the protective mineral layer progressively. Thinner enamel means less buffer between the tooth surface and the dentin beneath it, and dentin, unlike enamel, is sensitive, soft, and highly vulnerable to both acid and abrasion. Second, medications. The most common side effect of the most commonly prescribed medications in the senior population is dry mouth, clinically called xerostomia. Antihistamines, antidepressants, diuretics, beta blockers, ACE inhibitors, antipsychotics, bladder control medications. The list of drugs that reduce salivary flow is extensive and heavily overlaps with the drugs that seniors are most likely to be taking. The protective functions of saliva that I described, antibacterial proteins, pH buffering, enamel remineralization, all depend on adequate salivary flow. Seniors with medication-induced dry mouth are spending the night with even less salivary protection than typical, accumulating higher bacterial loads, producing more acid, and waking up with a more severely acidic and demineralized oral environment than someone without dry mouth. For these patients, the timing of brushing is not just a matter of optimizing enamel protection. It is a critical factor in preventing the accelerated tooth loss that xerostomia makes almost inevitable if oral hygiene practices do not adapt to compensate. A study published in the Journal of the American Dental Association analyzed tooth wear patterns in adults over 65, taking more than 3 daily medications compared to adults over 65 taking no medications. The medicated group showed significantly greater enamel erosion and dentinal exposure, and the pattern of wear was consistent with acid erosion combined with abrasive brushing, not simply age-related wear. The medications were not directly eroding the teeth. They were reducing the saliva that protects them, and the unchanged brushing habits were doing the damage in the vulnerability window that the medication-induced dry mouth had created. Third, root surface exposure. Gum recession, the gradual lowering of the gum line that exposes the root surface of the tooth, is extremely common in seniors, whether from periodontal disease, aggressive brushing over decades, or simply age-related tissue changes. Root surfaces are covered by cementum, a material that is significantly softer and more acid-soluble than enamel. The critical demineralization pH for cementum is approximately 6.7, well above the enamel threshold of 5.5. This means that the morning oral pH that has been declining overnight is already above the damage threshold for exposed root surfaces before it is anywhere near damaging for enamel. Seniors with gum recession who brush first thing in the morning in a high-acid, low-saliva overnight environment are brushing against root surfaces that are being chemically eroded at a far faster rate than their enamel would be even in the same conditions. Let me now tell you about something that compounds all of this, and that is almost never discussed in the context of morning oral hygiene: the role of mouth breathing during sleep. Research from sleep medicine estimates that between 30 and 45% of adults breathe through their mouth rather than their nose during sleep, with the prevalence increasing with age due to structural changes in the nasal passages, chronic nasal congestion, and the loss of muscle tone in the soft palate. Mouth breathing during sleep causes the oral tissues to dry dramatically. Studies measuring salivary flow in mouth breathers versus nasal breathers show salivary output during mouth breathing sleep to be negligible. If you are a mouth breather, and if you wake up with a dry mouth, a sticky palate, or lips that are dry and cracked, you likely are. The overnight oral environment I described is amplified considerably. Your morning bacterial load is higher. Your overnight acid production is higher, your pH is lower, and your enamel enters the morning in a more compromised state than a nasal breather's would. There is also an immediate morning habit that many seniors do that I want to specifically address because the research on this is unambiguous, and the behavior is almost universal: drinking a large glass of orange juice with morning medications. This combination, a citric acid load at pH 3.5, followed immediately by swallowing pills that require water, deposits acid directly onto tooth surfaces, extends the morning acid exposure window, and in many cases is immediately followed by brushing. For a senior with thinning enamel, exposed root surfaces, and medication-induced dry mouth, this sequence is about the most damaging thing that could happen to the dentition in a 10-minute window. The solution is not to stop taking medications. It is to take them with plain water, to rinse the mouth after swallowing, and to wait at least 30 minutes before brushing. Now, there is something I want to be very clear about before I give you the complete protocol, because the dental community itself is not entirely unified on this topic, and I want you to have an accurate picture of the debate. Some dentists recommend brushing immediately upon waking on the grounds that removing the bacterial film as rapidly as possible reduces the total acid load and limits further enamel damage. This argument has merit. Bacterial acid production continues as long as the bacteria are present and metabolizing. The counter-argument, supported by the enamel wear research, is that brushing in an acidic environment does more mechanical damage than the bacteria would do in the 20 to 30 minutes it takes to allow the pH to normalize. The balance of current evidence, particularly the in vitro and clinical studies measuring actual enamel wear under controlled pH conditions, favors the timing approach I have described. But the most important thing is that you have this conversation with your own dentist, who can examine your enamel, assess your gum recession, review your medications, and give you individualized guidance based on what they actually see in your mouth. Let me give you the complete morning oral hygiene protocol that the research supports. Upon waking, before anything else, rinse your mouth vigorously with plain water for 30 seconds. This is your first line of defense. It disrupts overnight plaque, begins to dilute overnight acids, and starts raising the oral pH toward a safer range without abrading the softened enamel surface. If you are a mouth breather or have significant dry mouth, this rinse is even more important, and you should take a sip of water and let it sit in the mouth for a few seconds before rinsing to begin rehydrating the dried mucosal surfaces. If you take morning medications, take them with plain water rather than juice or acidic drinks. Rinse after swallowing, then allow at least 20 to 30 minutes to pass. Use this time to shower, dress, make breakfast, do whatever constitutes your morning routine, while your saliva begins flowing again and your oral pH rises toward neutral. At this point, either brush before eating breakfast with a soft bristle toothbrush and a fluoride toothpaste, or eat breakfast and wait 30 to 60 minutes before brushing afterward. Use a soft or extra soft bristle toothbrush. Apply toothpaste that contains fluoride. After brushing, do not rinse. Spit out the excess toothpaste, but allow the fluoride residue to remain on the tooth surfaces for as long as possible. Rinsing immediately after brushing removes the fluoride before it can remineralize and strengthen the enamel surface. For seniors with dry mouth from medications, use a saliva substitute or an oral moisturizing gel before bed to maintain some degree of oral hydration overnight. These products contain compounds that mimic some of the lubricating and protective functions of saliva and measurably reduce the overnight bacterial proliferation that makes the morning oral environment so damaging. They are available over the counter and are inexpensive. Here is the summary of everything we covered. The mouth undergoes a predictable pattern of salivary reduction, bacterial proliferation, and acid production overnight that leaves enamel in a partially demineralized, vulnerable state by morning, brushing in that acidic environment. With or without prior acidic food and drink, subjects softened enamel to mechanical abrasion that removes mineral that saliva would otherwise restore. The problem is amplified in seniors by thinner enamel from lifetime wear, by medication-induced dry mouth that intensifies the overnight bacterial environment, and by gum recession that exposes root surfaces with a much higher acid demineralization threshold. The evidence-supported approach is a morning water rinse upon waking, a waiting period that allows salivary flow to restore and pH to rise, and brushing either before breakfast with fluoride toothpaste or after breakfast with a minimum 30 to 60-minute delay. Morning orange juice, vitamin C drinks, and coffee should not be followed immediately by brushing. Rinsing after brushing removes protective fluoride, and if you have dry mouth, an overnight oral moisturizer changes the biological environment your enamel wakes up in. Please share this video. The morning brushing habit is so deeply entrenched that most people will dismiss this information without a second source confirming it. Share it with someone who mentions their teeth are getting more sensitive. Share it with the parent who has always brushed the moment they wake up. Share it with anyone who drinks orange juice every morning and brushes immediately after. The enamel they preserve by changing this one sequence will still be there in 20 years. Subscribe to this channel if you have not already. My next video covers the other common oral hygiene mistake that is damaging senior teeth, even faster than brushing timing. And it involves something that almost everyone believes is protective. Subscribe so it finds you directly. I am Dr. Edward. Your teeth are worth protecting intelligently, not just habitually. I will see you in the next one.